Well, good afternoon, everybody, and welcome to the non-clinical PLT. It's been a while since we've arranged one of these, which is it's always nice when we can. So hopefully content today will be good. For any of those colleagues that couldn't make it today, we are recording it, so that will be shared up onto the website. Hopefully by Friday, depending on how much cleaning up I need to do of the recording. Also, I'll be sharing a link into the chat as well, which will have a feedback form. We'd love to get your feedback on this session, as well as giving you the opportunity to give us suggestions for any future sessions that you might want to see. But also if you want an attendance certificate, that is generated from the feedback form. So please be extra careful when you're entering your email address. Because it's incredible how many times I get email addresses submitted that have spaces, have commas instead of full stops, or forget to put the number that you are into the email as well. So if you can just double check your email address before you submit in any of these kind of things, just purely so that we can make sure that there's no delays in getting you your certificate. Or if you're joining an event like this, making sure you have the login details as well. So, not a huge amount to come from me. I was saying earlier, and in particular for those people who are just joining us, we are looking at doing a follow-up to the NHS pensions segment in the early part of 26, purely because there are rumours flying around at the moment that things may change on November 26th when the Chancellor delivers her budget. So we're mindful that that might be the case. So some of what you see today may become outdated, but we will do a follow up in the early new year. If you're anything like me, and bearing in mind that I'm 55 and I have an eye on some future date retirement, I've never been able to get my head around NHS pensions, so this will be a good opportunity, if you're like me, to finally get some understanding. In terms of the rest of it, not a huge amount of extra stuff coming. If you want to be included on our monthly newsletter, there's an area on the Training Hub website where you can ask to have yourself added onto the contact list, in which case you make sure you get the regular notifications. So without further ado then, I see our first speakers are here, so I'm going to introduce them now to give you the update on the Pharmacy First service. So if I can introduce Minnie, who is the lead on that, I believe, and then we'll take it from there.
Thanks, Craig. Hi, my name is Minnie. I work in the ICB. I've got my colleagues, Olivia, who works for the primary care team, and Aarti, who work in the medicines management team, who will be delivering this presentation for you today. I'll let them take it away from here.
Thanks, Minnie. So as you'll be aware, Pharmacy First has been in place for some time now. Our EMIS practices have had an integrated referral route from the start. Today we'll give a quick refresher on Pharmacy First service and then followed by an introduction of the new referral route now available for System 1 practices. So what is Pharmacy First? Pharmacy First is an advanced optional service with two main referral pathways. The first being minor illness, which was previously known as GP CPCS, and the second, which is the 7 common clinical conditions, and this is the newer extension of the service. Across Northamptonshire, we've got excellent uptake with 123 out of 125 pharmacies signed up to deliver Pharmacy First. The only two that are not participating are distance selling pharmacies. Next slide. So why is the service important? Pharmacy First brings clear benefits for both patients and for GP practices. For patients, it offers timely access to treatment and the convenience of being seen at the time and location that suits them. For GP practice, it helps free up appointments and reduces footfall, allowing for clinical teams to focus on more complex cases. So why are formal referrals required? Formal referrals are essential to ensure patients receive appropriate follow-up. If a referral isn't made formally, the pharmacist won't be aware that the patient may be attending and therefore not have the capacity to support the patient. Formal referrals also create an auditable trail from the initial referral route to the post-notification message, which helps close the communication loop and ensures continuity of care.
The TPP has officially launched a new integrated referral solution that allows GP practice teams to refer patients to the Pharmacy First service directly within System 1. This replaces the previous referral methods, making the process much more efficient. We've included a short training video in this slide that provides a step-by-step walkthrough of how to send a referral using a new system for you to watch at your convenience once the slides are circulated after today's PLT session. Using the new integrated system offers several advantages, including a more streamlined workflow with fewer clicks and significant time savings compared to previous methods. If you'd like more detailed guidance or formal training on how to use the new referral method within System 1, please reach out to Olivia or myself. Our contact details are included at the end of the presentation. We'd like to let you know about a regional Pharmacy First webinar that NHS are going to be hosting next Wednesday. To register, you can scan the QR code that's on the screen at the moment or use the embedded registration link in the circulated slides. We've created a dedicated Pharmacy First page on the primary care portal, which includes many resources such as our one-page inclusion and exclusion criteria posters, communication materials and user guides, including one on the new referral method within System 1. In addition, there's lots of national Pharmacy First resources available to GP practices, and the links to these are included on this slide. If you'd like to understand anything else about the new referral method or anything to do with Pharmacy First in general, please don't hesitate to get in touch using our contact details. Alternatively, you can speak to your PCN lead, as we do hold quarterly checkpoint meetings with them where Pharmacy First queries can be raised and discussed. Does anybody have any questions?
Just to remind you, you can put your questions in the chat if need be. So if you've got any, please share them with us now.
I'm going to stop sharing my screen. I think Minnie, have you got your hand up?
Yeah, I just wanted to reiterate on that webinar on 12th of November, which is going to take place in the afternoon. It's got several regional speakers, and also one is a regional pharmacy integration lead. We've got Anu Rao, who's the NHS England Associate Medical Director, and I think she's also represents regionally at our LMC. We've got practice managers, we've got GPs, and we've got PCN managers as well. So we're going to be talking around why Pharmacy First matters to general practice, the good practice and new developments which support it, which Aarti and Olivia have already mentioned, the positive impact it's having in reducing GP practice workload and how it can improve access for your patients, and how to maximize on your referrals, especially looking at the eligibility criteria and why formal referrals are important. So it'll be good if most of the people who are involved in triage and referrals are registered to attend that event. Thank you.
I see we have a question in the chat, this one coming from Anisha. If pharmacies have limited capacity for referrals, will this show when we try to refer through to System 1?
What we suggest is usually if, for example, a particular pharmacy is going to be closing early, or they're not going to be having the pharmacist, a regular pharmacist in there, and the locum is going to be a bit late, they should update their pharmacy profile so they will not show up in your formal referral process. So if you click your postcode, they will not come up as an option for you. But generally, I've not known where pharmacies are saying they're up to their capacity and they can't see patients. They would try and slot them into their calendar when they have capacity. So what we would suggest is when you make this referral via System 1, make sure you pass on the pharmacy phone number to the patient and ask them to ring the pharmacy and book in a slot that's convenient to both of them.
Did you want to come in on that as well?
I wasn't really going to come on Minis, but I just wanted to introduce myself. So, hello everybody, my name's Rita. I represent all the pharmacies actually in your areas. So the reason I wanted to just say a few words is that Pharmacy First, if it becomes business as usual, where you are referring patients regularly, then the scenario that's just been mentioned, that is managed quite easily. I think where the problem we have from the feedback is when the referrals are just maybe one day, and then you don't see anything coming through, that's when pharmacies aren't able to incorporate it into their normal workflow for the day. So my ask is, one, the more regular we do these referrals, the better it is in terms of workflow and patient outcomes. But the other thing I wanted to say is that if any of you have not done or not doing very few referrals and you want to do a big bang, which is, do you know what, we want to go out, we want to make this part of our regular workflow, that any phone calls that come in that fit in the scenario, we'd like to send them to pharmacies, but you don't have the confidence that the local community pharmacies are going to be able to deliver on the promise that we're making you, then if you want to contact me, my number and name is on the last slide, then I can work with your local pharmacies. So we can do a joint approach where we can have meetings with either yourselves or your practice managers, the local 2-3 pharmacies that sit in your area, and we can work together so that we can put processes together which are very local for your particular surgery. And we're happy to do that. And that way we make sure that both pharmacy and GP practices are on the same page. And actually, this is about the best outcomes for the patients, that they're seen at the right time by the right person. So don't hesitate to contact me if you want to do a big bang. I can work with your local pharmacies and yourselves, and we can make sure that we can put some local processes together. Thank you.
Thanks, Rita. Just posted the link on the chat for that event. Yeah. Thank you.
Just an observation coming through from Sheila Little about slides. Can we try to make sure that the slides are shared? Which, yes, we will, and we'll publish them up onto the website.
You can see another question on the chat as well, that do we need consent from patients to pass their details on to pharmacy? So pharmacy are NHS clinical professionals, and if as part of direct care, you would be discussing with the patient anyway that you're going to be making this referral for them to go and see the pharmacy, and they would be eligible for that service. So I don't think there's a consent issue here, unless the patient's actively saying, I don't want to see the pharmacist, I absolutely want a GP appointment, then that's up to you how you respond to that. But as far as governance is concerned, if it is part of direct clinical care, you can make referrals to community pharmacies.
If I could, I'm so sorry, I didn't put my hand up. If I can just come in there, Minnie actually did say something that's so relevant, because my husband is part of this, where he will ring a GP and want to see a GP, even though he's married to a pharmacist. And in terms of that, we can help you. So I've done some slides where it will be the correct wording to use with your patients, so that it's not saying, no, you can't see a GP, but the correct wording, which gives them the confidence to say, actually, I'm seeing an equal, excellent healthcare professional. So if you need support like that on what wording to use, the reception teams, to make sure that the patients understand what the process is, etc., again, contact me and I'll share what we have.
Sorry, Craig, I've just seen another question there.
No problem at all. Keep going.
Okay.
Still we're waiting for our next speaker to arrive, so there's plenty of time.
just stop us when we've got to stop. So I've seen another question there around anima Anima triage and whether it is, since you think it's integrated, will the patient be notified if pharmacy is able to or not able to deal with the complaint? Olivia, did you want to answer that around our Anima conversation?
Yeah, of course. Yeah, thanks, Minnie. So the ICB, we have met with Anima to kind of understand how their referral route works, because it's slightly different. So there's a couple of sort of barriers with the Anima system. So at the moment, the way that it works, the postcode is only set until a point of where the GP practice is. So, for example, at the moment, if you're wanting to refer a patient and they were working sort of out of county or working in town centre, for example, and your practice was more rural, you could refer the patient to a pharmacy that was closer and more convenient to them. But unfortunately, at the moment, the way that Anima's set up, it's got the postcode is set around the GP practice, so it would show those pharmacies that are sort of local to that area. So there's a little bit more work in terms of that as well. Also at the moment as well, the Anima system's not read coding, so once the referral is sent, it's not sort of automatically read coded either. So it's just, these are just sort of pointers. You're more than welcome to use obviously the Anima system if that works for you in your practice, but it's just making you aware of these sort of issues. But we are working closely with Anima to kind of see how they can change that, and hopefully I think with a bit of noise from ourselves and other sort of systems that they will sort of work on that. But like I said, it does work, but there's just these sort of a couple of barriers, I guess, with the Anima system.
But so one of the elements I don't know if you were thinking of is if the pharmacy has had that referral as a formal referral, they will be able to let you know through GP Connect update records whether they actually saw the patient or didn't see the patient and what the outcome was. So that's why we insist on formal referrals rather than informal signposting. So if the patient contacts them and if they've seen the patient, you will get an outcome. But if the patient don't contact them, if you've made a formal referral, the pharmacy will update you on what happened. So yeah, that's another reason why we need to make formal referrals. Oh, thanks, Aarti. Posted the link. I mean, Craig, feel free to stop us. But the other thing I thought while we have the time here is just to update you all on some of the services that has been updated in community pharmacy on 29th of October. So you have the pharmacy contraception service running over the last 2 years, where we already have where we had community pharmacies supply medications for contraception on a monthly basis, and they could also do the annual check. From October, these pharmacies who are signed up to the oral contraception service will also deliver emergency hormonal contraception. So we've got 122 pharmacies signed up for the contraception service who will be doing the whole package of emergency hormonal contraception, initiating contraception for patients, whatever is appropriate for them, and also making the supply and the annual review. So that's a whole contraception women's health package that the practices could make use of to release some capacity within your practice. There's also a new medicine service where a new clinical condition has been included, which is depression. So patients can be referred to pharmacists if they've started on a new medication for depression, and pharmacists will be able to counsel them on that. I don't know if I've missed anything else, Rita or Aarti. Craig, are you happy for us to keep going then?
Yeah,
we've got plenty
for now,
to talk about.
Paul, I've just spoken to Paul Gordon. He's just literally about to join in. So if you want to keep going for a couple more minutes, that's great. Thank you.
Okay. Okay.
If we have a couple more minutes, is it worth us sharing the video on the step-by-step process, just based on Ruth's question? Everyone happy with that? Just a 4-minute video?
It'd be great to have more questions if we can, just because I'm hoping we can support people. But if not, the video.
Sorry, are we not playing the video then?
We are ready for our next speaker.
Okay.
So if you don't mind, can we park it for now? I think maybe
Yeah.
a follow-up session might well be an idea. And I'll share the link to that video on our website as well so that people can see it.
Thank you.
That's
Thank
brilliant.
you.
Thank you very much, everybody. And
Thank you.
now I think we'll just crack straight on with it. And I'd like to introduce Paul Gordon. Paul's from an organisation called Atemos. I think that's the right way of saying it. And a bit of an expert on NHS pensions.
And this is probably the best timed session ever after the shenanigans from government yesterday, where not a great deal was announced. I think you've got me for about 45 minutes to try and decipher what on earth has been going on pension-wise, but also how things are looking, what you need to be aware of, and then just ideally how to take stock of your position and make sure that if you are engaging with any of your colleagues, if they have concerns, just so they understand what's going on. So in terms of outline, we'll run through the 3 schemes that exist. We'll make sure that you understand the different retirement ages, how they accrue benefits, and there are differences for GPs and indeed employees. Some acronyms, apologies, RPSS, Remediable Pension Savings Statement. Now, not all of you are likely to receive these for 2 reasons. They haven't all been sent out, and some of you may not need them. In short, if you were moved from your old scheme to the new shinier version based purely on your age, the government will unravel that. And these statements confirm how much the difference is in terms of your annual allowance growth and so on. And then a very quirky bullet point around contingent decisions. So very mindful there'll be a complete spread of people within the room, but if any of you opted out of the pension or stopped your added years or similar because of being switched to the new scheme, believe it or not, you can now unravel that. It's called contingent decisions. I'll run through it. I'll make sure you understand how it works. And then just a few other points. The lifetime allowance has been abolished, but it still remains relevant. The annual allowance sadly hasn't been abolished yet. Rachel may come good in 3 weeks' time. We'll wait and see. For those of you that have personal pensions or investment-linked pensions, by the look of things, from April 2027, they're going to be included within your pension and also within your estate for the purposes of inheritance tax calculations. And then without question, my favorite, how to get your money. So be it 24-hour retirement or more recently known as retire and return, or indeed partial retirement, or simply stopping work altogether. Although if I think I signed off on that, I'd be in trouble probably with the area team, but also with the NHS itself. So we shall see on that one. For those of you that have seen me before, by all means, if you're comfortable attacking me with questions as we go, you're more than welcome. You're more than welcome to pop them in the chat box. I've got it open and I'll try and pick them up as we run through to try and ensure that for everyone listening in, there's a complete understanding as to what's going on. So, the schemes. Who joined the NHS pension before April 2008? If you did, by all means, go with thumbs emojis or similar, but if you did, this is the scheme you joined. And crucially, if you are an employee, be it a nurse, be it practice manager, administrative staff, and so on. Debbie, is that a quick wave? Yep. You accumulate benefits in this version of the scheme based on your final salary. And be very clear, final salary here, Laura seems happy, final salary here is deemed to be the best of the last 3 years at retirement or leaving the scheme. whichever is the earlier. So if we can persuade any of your practices, the ICB or whomever you're working for at the moment to give you a pay increase, if you pay in for just 12 months and then retired, the whole of the increased pensionable income will be included to calculate all of your benefits in this version of the scheme. So not only would it enhance the pension forever, it would enhance the lump sum as well. Lump sum, sadly, is a one-off payment. And you accumulated benefits to translate fully at 1/80th of your final salary for every whole year you paid in. So if you're working 37.5 hours as an employee, that would be considered whole time. If you're working half of that, you wouldn't receive a full 80th, you'd receive half each year you paid in. Now, the key components of this scheme, it's based for employees, as I said, on final salary, but whole time equivalent. So if your pensionable pay now rises and you're still only working half time or whatever it may be, it's on the whole time equivalent that will be used. It's accessible fully without a reduction from age 60. So if you wanted to retire early in this or either of the two other schemes, you can. You lose about 5% or so of the pension, just under, and about 3% of the lump sum in this version of the scheme. It's a fantastic opportunity. We've seen quite a few people around the country drawing their pensions early for whatever reasons. But this one has the earliest retirement age for most of you as 60. Does anyone have any special class status? Any nurses listening in? Maybe psychiatrists, maybe physios and midwives. Potentially with special class status, you could take this pension from age 55 without a reduction, and you can still go back to work. And then lastly, any GPs listening in, be you in a locum position, a salary position, or indeed partnership, your benefits in this scheme were calculated differently. You've got 1.4% of your pensionable earnings as a pension for each year you paid in, and it was added to an ongoing pot from which you would draw this 1.4% at retirement. Same pension, same lump sum as everyone else, just calculated differently. Okay, who joined after April 2008, but before April 2015? If you did, this is your first version of the NHS pension. You can see that normal retirement age has shifted back from 60 to 65, but to compensate, rather than 1/80th, they'll now provide 1/60th of final salary, but it's calculated differently, sadly. So for those of you in this version of the scheme or have membership in this version, crucial to understand that your final salary is deemed the best of the best average 3 consecutive years within the last 10. So anyone in this pension scheme originally that was, for example, a practice manager, but looking to reduce workload, perhaps become assistant practice manager. In the old scheme, if that reduced your pensionable pay, that could cause a problem if you kept paying in for too long. You're actually paying towards having a lower pension in retirement. This allows a bit more flexibility. So if you were to reduce pensionable pay, say 5 or 6 years out from retirement, because you're reducing workload in terms of stress levels, so the hourly rate dropped from £20 an hour to £10 an hour, it would potentially mean that you could access the earliest pensionable pay figures, maybe 5 or 10 years out from retirement, would still keep things higher. Special class service available if you had break totaling 5 years in 2 episodes. Julie, very good question. Potentially on that one, there's a danger there depending upon the roles you'd return to if they didn't qualify. What I shall do at the end of the session, if it's okay, I shall email across just some helpful options, really. So be it contact details for NHS BSA. So Julie, in that case, I'll give you a direct contact. You can just check to see if you've got special class status. They'll understand the request and you can send that across. But also the likes of PCSE and so on. Anyone that's having issues with PCSE, I can put some cheat codes in there and try and speed things along. One error on caution with regards to being given sizable pay rises. Has anyone heard of final pay controls? Or has anyone sadly received some of the correspondence whereby the practice has been charged in some cases, quite sizable charges because someone was given a pay increase and then retired. In short, it was created to stop typically husband and wife teams, where one was a GP, one was a practice manager, and they were trying to stop the practice manager's income being inflated with just a year to go. It's caught out quite a few practices over the years. So if you have any staff, or indeed if you're a member previously of the 1995 scheme, just be careful with that, please, because what it could mean is if you were to give too great an increase, and it can be you promote someone from within, whereby assistant practice manager becomes practice manager, that increase in pay could trip up the practice if they subsequently left and retired. So just be careful on that, please. And then this hasn't been a popular question, but is anyone planning on retiring later than age 65? Anyone perhaps retiring 67, 70-ish, 75-ish? Fine, thank you, Lisa. I'm not sure everyone can see that, but I've got a definite no there from Lisa. There aren't many that are currently proposing to retire late, but in this version of the scheme, and indeed the newest incarnation, you're able to actually receive what are called late retirement factors. If you kept paying in and retired after the normal retirement age, they would enhance the pension. We've got a couple of yeses, actually. Jane and Sue, I'll be intrigued by that. We'll pick up on those later on if we may. But it's trying to give you greater benefits for staying in and looking to actually just ideally add more to the pension pot. But of course, the one thing to be sure of there, you're shortening your retirement. So please give that some thought. And then a question in from Laura. I know the government offer 1 hour pension-wise advice for free. Is there a similar scheme to speak with someone about the NHS? Not really, which is where there's a natural flaw. It's the largest pension scheme in the country, and there isn't, which is why Mel and her team ideally try and lay these on. This is the second, and we met at an accountancy conference. I'm a financial planner, and but we met at an accountancy session where I was speaking. There isn't anything just yet. If anything changes on that, I shall let Mel and the team know. But sadly, these sort of sessions are probably the best. Crikey, that's optimistic. These should give you enough of an update to understand what's going on. Let's go with that, Laura. So this is now the scheme that everyone is paying into. Doesn't matter when you first started. Doesn't matter your role, your age. If you are paying into the NHS pension, this is the version of the scheme you're paying into. Complete change. You can see the normal retirement age now is linked to your state retirement age, which I think Rachel Reeves will announce in 3 weeks' time is now 105. It may be a fraction higher, depending on how much tax she wants to raise. At the moment, the highest is 68. For some, it'll range from 66 through to 68. But that's what it's linked to. So you could see that someone with special class status had a normal retirement age of 55. In this version, it's gone up 12 or 13 years, depending upon their age now. It's calculated the same for everyone. Doesn't matter if you're a GP, practice manager, administrator, or any other role, it's calculated the same way. And you effectively accumulate a pension based on 1/54th of your pensionable earnings. So if I just use some rounded numbers to make the arithmetic easier for a Wednesday afternoon, if you earn 54,000 a year, 1/54th of that will give you a pension for £1,000 per year in retirement forever. And one really important note here, the pension in retirement increases every single year by inflation. And the inflation figure used is the consumer price index figure for September. And then the uplift is applied every April. So whereas you're hearing pretty much daily at the moment, the cost of living concerns that are being or causing chaos around the country, what is actually happening within the NHS side of things is it continues to rise. It rises every year. Better still, for those of you that are paying in, and we've got 200 plus people today, I would hope the majority are paying in. Because you paid in this year, all of your preceding 2015 pension benefits have increased by consumer price index plus 1.5%. They actually increased by more than inflation. So in terms of pension benefits, you're actually able to buy more this year than you could buy with the same pension last year because it's risen by more than inflation. From a pension perspective, very good. Is there anything we at Atomos could prepare or send across that can rivals this? No. Investment-linked pensions. This has been a very good year for investments. Your ISAs should be up. Any stocks and shares pretty much should be up. Pension funds are up. The NHS pension only ever rises. It goes up year after year after year. Please bear that in mind for those of you that aren't yet in the scheme, because there is nothing we could put forward that compares. And then just some of the jargon on the screen. CARE is career averaged revalued earnings. And effectively, it just means that whatever you earn each individual year, 1/54th of that is your pension for that year. So I mentioned 54,000. If you earn 27,000, for example, you'll add about £500 a year to your pension at retirement age. But you'll do that every single year. You earn that same £27,000 and so on. So you can see it accumulates quite quickly when it gets going, particularly as it uprates by more than inflation. You'll see that the words lump and sum are missing. There's no automatic lump sum in this scheme or indeed the 2008 section. You can take a lump sum at retirement, but you choose to give up £1 of your pension for £12 of lump sum. You do that at retirement. And then again, late retirement factors, as I mentioned earlier on, apply to this scheme, but they're late retirement beyond your state retirement age rather than age 65. So some of the yeses, so Sue and friends, if you're still a yes after this one, again, you're paying in, government will effectively enhance this pension. They'll give you more. A couple of questions. Is it possible to nominate another person to receive your pension should anything happen to you prior to retirement? Kind of, Christine. My full name, should you want it to be me, is Paul Andrew Gordon. Failing that, if you're looking at other people, the pension itself, for everyone that is married or with a civil partner, the default position is that if I can kill someone off yesterday, the pension will be payable for the rest of their lives as a survivor benefit. So it's not the full pension, it'll be a reduced figure, but it's paid to your partners for the rest of their lives upon marriage and civil partnership. If you have someone that you are financially interdependent with, so live with, children together, same bill account, and so on, then they may receive it, but you need to nominate them with a nomination of beneficiary form. If you don't live with your partner, if they're not financially dependent upon you, if you simply don't have a partner, if you died, then there would be no ongoing income payable, but there would be a lump sum. If you're within the scheme, it's called a death in service lump sum, and you can nominate whomever you choose. So it can be, often it can be children, it can be partners and so on. There's a nomination of beneficiary form. Christine, I'll pop something in the email to Mel and her team later on, if that's all right. And then Joe, if we have money missing from our pension pots, does it all work out once it's rectified? Right, crumbs. I'm going in. I'm going to be brave. Are we referring to some organisation called PCSE that on occasions may make tinsy-wincy errors? If we are, it doesn't come as a surprise that that's replicated around the country. So what is crucial? Your GPs, they complete a type 1 certificate of pensionable profits if they're partners, and quite often the accountants do that. Your salaried GPs have to complete a type 2 certificate. They are responsible, and often accountants don't do it for them because they're typically not paid. Some of the better accountants now are starting to incorporate that. So that covers salaried and partners. Locums would fill in forms A and B. They are notoriously easy to lose, along with the contributions. And then for you, if you're not a doctor, or staff, if you assist on that front, it's about record keeping. So if someone joins, someone leaves, making sure that the record is either opened or closed. We've got a retirement. I can give you a live case from this morning. It's a GP whereby PCSE have only got one open role the GP in question has 3. So not only can he not close the records because they don't exist, he's got to open them, clarify all the details, then get them closed off. So from a question perspective, Joe, what I'd suggest, again within the email, I'll include what is called an SM27A form for you. Not particularly catchy, but what it will allow you to see is your career histories. So as long as you started before 2015, it will show your career history to date, every role you've had, pension payments that have gone in, and so on. And it'll break it down. It'll give you a much clearer understanding as to errors or not. One of the other questions that came in was from Rachel about amalgamating other pensions. Rachel, a bit more difficult to answer that one. Possibly is the answer. You're not able to transfer external pensions into the NHS after working and paying into the NHS pension for more than 12 months. So if you've been there for more than a year, you wouldn't be able to do it. Otherwise, potentially you can, and they'll give you an illustration to show what other pensions are worth if they're transferred into the NHS. There's a couple of dangers, one of which is you may be able to access the other pensions earlier without a reduction, because don't forget the scheme you're transferring into very likely to be the 2015 scheme linked to age or your state retirement age, so as much as age 68 and so on. So just be careful on that. Sadly, I try and give as many definite answers as I can. That one, there's a bit of grey, and there's quite a lot of grey depending upon what you've got and where it sits. So possibly is the best answer, but that 12-month time frame quite often catches people out. Anita, however, I also had an NHS pension error. Okay, despite sending me an email saying it was attached, yeah, that's cool. They then said, I'd never worked today. Great. I now have that rectified. Right, okay, yes. So if you are an Anita type scenario whereby you've had quite obvious glitches in history, be it records not being correctly submitted, not necessarily by you, but when they're processed, that SM27A form will outline the history, and those gaps in service become quite clear. And reconciling them can be straightforward for those of you in the group that have kept every single payslip or every single submission to PCSE. For most of us, we have some payslips, more recent ones, but not necessarily something from 10 or 20 years ago. So it should reconcile it. We have numerous conversations with PCSE on a rolling basis. And what I'll do, as I said, I'll send you the PCSE complaints email address, because actually they're really good. I will not speak ill of them. As a department, they're wonderful. Linda, Donna, Con, Lance, and a few others are just great. And when you get through to them, they'll even phone you to reconcile problems. They're really good. But I'll send you that link so you've got that for you. Chelsea, I presume the presentation will be shared. If not, I'll send a copy of slides so you've got them. Does anyone know how we go about getting a pension statement for? Yes, Christine, you log into My NHS Pension. I will send you the link. More of a follow-up email, which is growing ever longer, actually. And within that, it'll be a link. You'll be able to log into it. If it's not successful for whatever reason, I'll also give you an email address where you can organise a manual estimate of benefits. You can do it automatically. And then last question, I think, before we'll move on. I started my NHS pension in Northern Ireland, having issues. Yeah, crikey, you would be. What would I recommend? I'm happy to fly to Northern Ireland to sort it. Their department is akin to PCSE, actually, over there. Laura, can we take that one off grid? Pop me a message later on. I'll try and give you some better answers, if that's okay. So, a couple of things that are quite significant. Again, you're more than welcome to show me thumbs up or similar. Did anyone cease paying into the pension between the 1st of April 2015 and the 31st of March 2022? If you did, and it was as a result of not wanting to join the new shinier scheme, 2015 scheme, or incurring tax charges, or a combination of the two, you're able to unravel that decision. That goes for you listening in, for all of your colleagues back at the practices, all of your GP partners, and so on. You can unravel it. It's called contingent decisions. And the largest we've dealt with so far was a cost of £131,000 to buy back all 7 years. They were quite high earning, but they bought back all 7 years. And it topped up their NHS pension from age 60 and their lump sum automatically, and it works for them. Now, not everyone has gone for the full amount, but you're able to buy some or all of that missing service. So for those of you that did opt out, stopped your added years, or just changed the way you did things, potentially there's some scope to use hindsight to buy some of that service back if you choose. And then, as I mentioned, the acronym earlier on, Remediable Pension Savings Statement. Has anyone received an RPSS just yet, or anyone heard of them within the practice meetings? We're still short. We think it could be as much as 10,000 short. And effectively, they outline what your pension growth has been each year. And there's been different allowances. Currently, the allowance sits at £60,000 a year. Crucially, that's not what you pay in, it's how much it grows by. So going back to my point earlier on, if someone's given quite a large pay rise, that pay increase could give a spike upwards in growth. If someone has quite a large set of earnings, or they have non-NHS earnings, interestingly enough, the allowance, the amount you're allowed to grow your pension by, could reduce. An RPSS is imperative because it will just outline that your growth has previously been X and Y. It should not have been those numbers because you were moved into this new scheme illegally. The jargon terms, McLeod remedy, McLeod judgment, they're the two. And effectively, it will give you, hopefully, in listening in, some will receive a tax refund because you paid too much tax at times where you were growing the pension because you had two sets of growth going in. For others, it may actually lead to a tax charge, although we're seeing probably about 1 in 4 are receiving a tax charge. The other 3 are receiving tax refunds that we're processing. So it's pretty good news. The ratio is good. Mark, hi. How do we start sorting contingent decisions? Mark. Mark, are you a GP or an employee in some format? And the only reason I asked that, okay, yeah. So Mark, are you happy to share? Well, actually, is everyone happy to share? Let me run through essential difference. Medical specialist accountants are brilliant. They will save you and your practice hours. Non-medical specialist accountants can use ChatGPT and other options, but they can cause headaches for you. So Mark, depending upon which accountant you use, they will be able to complete a contingent decision request form with you because it needs the income figures for each year during that 7 years that you had opted out, or each part year, and there's calculations that need to be complete. That form then goes off to NHS BSA for processing, and then what happens is it comes back and they say, Mark, and I'm just going to use a round number, to buy back your service, Mark, is £50,000. What it doesn't show you is what buying the service back will lead to, what extra benefits it will give. So then that information then needs to be run again, and what will happen thereafter is you'll find that your 50,000 of contribution, you don't pay all of it because you'll receive some tax relief. You don't pay the employer contributions either, which is a huge upside for partners. And it will gain or grow your pension benefits by £10,000 a year. And you'll weigh up if that's good or bad news. The ones we've seen so far on the whole are very, very good. But it's going to involve you, your accountant, and then probably a third party to run the numbers, depending on which accountants you use. But again, much the same as I mentioned earlier on, quite happy to take that off grid if that's okay, and you can pop me an email or whatever, and I'll give you some answers. And I'm glad to see Ashley and Lisa chatting away. Sorry, you two. My NHS pension, it will. You'll register, and they'll send you a login code. I will get that within the email this afternoon, I assure you, just so you know what's going on. And hopefully within the next week or two, you'll all be able to see what your NHS pensions, plural, because you may well have 2 schemes, what they look like, when you can access them, if there's a lump sum automatically, or you've got to take a lower pension for a lump sum and so on. But at least you'll have an understanding as to where you are. The one err on caution, if you're early on in your career, please, please, please remember that the figures will look quite modest because they haven't got going. This 2015 scheme that I mentioned will rise by consumer price index plus 1.5% for every subsequent year you pay in. It's extraordinary. It rises by more than the cost of living, and please hold that thought when you're looking at it. This isn't a particularly fun slide, actually. It refers to the lifetime allowance. The best part about it, in the main, it's been abolished. So Jeremy Hunt, great guy. No, we'll skip that. He abolished it. It's gone, good news, but it still has some relevance to maximum lump sums that can be taken tax-free. And as a result of that, I leave the slide in at the moment because you're able to take up to £268,275 tax-free unless, and the penultimate bullet point on the screen there is key, unless as of the 5th of April 2016, you had a pension pot or pots added together that notionally exceed that 1,073,000 figure on screen. If you did, you can still secure some protection. My suggestion to anyone where that may be relevant, the RPSS that I mentioned gives a set of numbers that can be recalculated to work out your lifetime allowance position. It's not the same figure, but it allows an estimate to be used to see if you would have exceeded the 1,073,000. And although I've put a deadline there of April 2027, we have a budget in 3 weeks and I've got no idea what Rachel is going to do. So I try and find the numbers sooner and try and secure the protection earlier if it's relevant to you. And in a room of 250, there'll be a few of you, I'm sure. But definitely check that. It'll be RPSS and then work it backwards. I can show you how it's done if that's of any use. And then one last point on inheritance tax and private pensions that I mentioned very briefly. If all goes to plan for government, they're going to include the private pension, so anything that is investment linked within the calculation for inheritance tax from April 2027. So we have a little while, but it's only 18 months. And for some of you with extensive private pots that have been accumulated somewhere else, be it a different employer or you've accumulated a private scheme outside of the NHS, to have that included seems incredibly unfair. But that is definitely the direction of travel. It hasn't yet been passed through the Lords, but that's definitely on the radar. And we've seen the content from government so far. So just be careful of that, please. Look at your overall estate value when considering what your options are going to be. And then here comes some good news. Finally, we're half an hour in, and I've just hit you with not the fun side of things, really. 24-hour retirement, partial retirement, or just stopping fully. Now, has anyone got any colleagues within the practice that have either taken 24-hour retirement or partial retirement just yet? They are both great options, but they're different. They are hugely different. So the top one, 24-hour retirement. If you are an employee of a partnership and you want to access your pension, if the partnership agree in writing, you can go, take a day off, come back to whatever role you've agreed and receive your pension. So be very clear, you need written confirmation. So we'll make today your last working day. The practice have said you can take tomorrow off. You can come back on Friday. You'll be in receipt of your pension forevermore. Your lump sum is normally paid on the day of return or thereabouts. Pension, a month in arrears, and then your ongoing earnings. There is no criteria now around a minimum or a maximum number of hours that you can work if you take 24-hour retirement. But please be aware you break your contract if you're an employee. So if you wanted to work 37.5 hours from next week onwards, but the practice said actually you can work 20, if you press the button on 20, that's what you'll be working. So just be aware of that. And likewise, they may not give you a permanent contract. It may be rolling. So quite a few of the trusts, consultants found that as a problem. Trusts would normally give a rolling contract rather than a permanent role. For GP partners, two components here. Similar scenario, written confirmation is absolutely paramount from both the partnership and indeed the ICB. But just check, for those of you that have got partnership agreements, that they're up to date. If they're drawn up by, who have we got, BWV, Capsticks, DR Solicitors, BMA Law, a few others, that are medical specialists, it should be included, but check it. Please check it and make sure that you have written confirmation from your partners that you can go and come back. And if you do, that's it. It's a one-day break. But it's a one-day break from all of your roles combined. So anyone that's got multiple roles, partnership, appraisals, ICB, you name it, education and so on, you have to take a 24-hour break from all of them, preferably the same day. But it can be last day today, day off tomorrow, back on Friday. Partial retirement, different, hugely different, because you remain in your substantive role. So again, if I can break it down into GPs and indeed employees first, you must have a 10% reduction or more in your pensionable earnings for 12 months or more. And it must be a contract variation. So not a new contract, but a contract variation. So the practice, the ICB, whomever your employer is, will write confirming you can now work at 90%, because that will reduce your pensionable pay by 10% or more, or to whatever a lower figure for 12 months. Now, of the partial retirements we've seen, I don't recall any going back up, actually. They've all stayed at 90% or lower. But you complete two forms to draw the pension under partial retirement. One is an AWA, and there's a supplementary form as well, which just outlines that year reduction. Essential again that you just get agreement. Don't just do it. And then the bottom bullet point on there, which I've left, last year was my toughest year for dealing with ill health retirements. So admittedly, I've dealt with a few, so it may be that's now known. Cameron Fund will give me a call, or others from around the country. I dealt with 11 last year. This year I've dealt with 13, and we still have nearly 2 months of the year to go. So ill health retirement is becoming more prevalent. And the good part about ill health retirement, it's an unreduced pension. So even if one of the questions I think is I'm 46, if you took your pension normally, which you couldn't, but because you are so early, they would reduce it. Huge reductions if that were to apply. Ill health retirement, there's no reduction. And in fact, depending upon the severity of the illness, there could be an enhancement. So for those that are poorly, I can give you some examples. We've used their income protection rather than claiming ill health retirement, because their income protection is paid tax-free, and the pension would be taxable. So if anyone, if your income is really important to the family and you haven't got income protection, please just look at some figures. Similar to the mortgage, crumbs. If you have a mortgage, just make sure it's protected in the event of a disaster. But certainly ill health retirement is becoming more and more prevalent across the country. And make sure, if you have a partnership agreement, make sure it's included. Make sure you decide before it becomes a problem as to what the stance will be. Because here's something that will sound ridiculous. The definition for ill health retirement is permanently unable to fulfill your role because of illness or injury. You can take 24-hour retirement and go back to work. There are limitations on how much you can earn, but you've just been granted permanently unable to fulfill your role, and you can still go back to work. So be careful with that, and please be aware of that when setting up your partnership agreement. I've seen that in a few now starting to appear, especially as it becomes quite clearly something people are considering. A couple of questions, if I may. Is this just when you reach retirement age? Yes, it is, Carol. So it doesn't have to be, you have to be 60, 65 or your state retirement age. You can do it earlier, as I said, but it would be reduced. You're seeing some, because it's partial retirement in particular, saying, well, actually, I'll take some of my pension. I won't take all of it. I'll take some, because actually I want to cut my hours down. I want to improve lifestyle and so on. Others are just saying, well, actually, I'm 58. I'm in the oldest version of the scheme as well as this new version. I'll take all of it. Because I'm going 2 years early, it's reduced by about 9%. But actually that works. It allows me to ease back on my workload, and I'm very aware of practice workloads. So it allows people some more free time, probably time just to catch up on sleep, I would hope, for the first few years, or just rest and recuperation generally. And it certainly works. And then Claire, at 46, sadly, you're about 100 years away from format. What will actually happen there is, for everyone that's retiring tomorrow and onwards, you'll be given two options. And the McLeod judgment effectively says, would you like to have kept all of your service in your oldest version of the scheme until the end of March 2022? Or would you have liked to have switched to the new scheme at its very earliest point from the 1st of April 2015, or whenever you moved across? And they give you the figures. They give you the individualized figures to show you which option works for you. They are yours. So if option A is higher than option B, that's probably the right answer. Likewise, option B better, well, hang on. And an anomaly on that, one of the ill health retirements from earlier was granted tier 2 ill health retirement, which is the more serious, and the enhancement within the new scheme was favourable. So we moved them to the new scheme from 2015. We moved them early. Excuse me. Carol, hi. How do you find out how much you would get if you retire early? Carol, crikey, this is some email I'm sending across. Effectively, there are early retirement factors. And like I said, it's about 5%. It's just under for each year you retire early. So your estimate will be 10,000, 20,000 or whatever it may be. And then you'll just take off however many whole years you're retiring early in terms of percentage. So let's say you take off 10%. If it's a £20,000 pension and you go 2 years early, you get about £18,000 a year. Jude, when can you apply to get the lump sum? Right, okay. So Jude, perfect. Any application via an NHS GP practice goes via PCSE. If you're still paying in, it goes via PCSE. We're probably, if you're planning on taking pension in November 2026, we've probably missed that deadline. I'm teasing, Jude. It's about 5 or 6 months. It's still a long time. And what I'd suggest is that by making sure that everything is up to date, certificates if you're a GP, your employment record if you're an employee, if all of that's up to date, when you press the button by submitting your AW8 form, then hopefully everything should be processed quite serenely. Lump sum arrives day of retirement, if that's what you're taking. Indeed, pension arrives a month later and so on. Hopefully, always worth checking along the way. Jane, I'm in 2008 scheme. Okay, to partially retire at 65, yeah. Can I take a lump sum option from at 65 from the 2008 scheme? Yep, and you can take one if you've got benefits within the 2015 scheme. And the crucial thing, you give up £1 of income for £12 of lump sum, and you only decide it when you want to draw the pension. So having a session now, you don't need to worry about that. But in 2 years, 10 years, or whenever you're age 65, if that's the plan, about 5 or 6 months in advance of that, as we were just saying for Jude, that's when you complete that form and it says, would you like a lump sum, yes or no? Yes, please. It either gives you a monetary amount, how much would you like, or you can tick maximum tax-free or maximum that may be taxable. You decide. But there are 3 options there, so you decide it at retirement. And then Marion has written a fair extract. Marion, can I read that afterwards and then give you a better answer? Is that all right? Just to make sure that I don't run out of time, but I'll pick it up in a second if that's okay. And then last slide, which hopefully is a sigh of relief for everyone. Just when? So actually a few of those questions coming in just now were 65, 60, a bit earlier at 46. Try to make sure that whatever you do financially is for you and your family, not because somebody else has done it, whomever that may be, not because of them. So please don't disclose anything in the chat or whatever, but some of you will have mortgages. Many will have children, or debts and liabilities, or aspirations to travel or buy a camper van or help the children with house deposits, which might cost more than a camper van these days. But whatever it is, make sure that you've mapped through where you are. And what it will show you is that, well, actually, I've got my pension record. It shows that my pension is 20,000, 50,000, whatever the number. well, actually, we only need 2,000 a month because we've got whatever going on. We've cleared our mortgage, the children have left home and so on. Well, you could go early. You don't need to be around till 60 or 65 or beyond. Likewise, the reverse of that. Well, hang on, we need much more. We need double the figure we've got. Well, you either trim your expectations around retirement, or we have to come up with a different plan, which might be that you save a bit more, you pay off the mortgage earlier. It could be that you use some of the lump sum to fund lifestyle, or pay off some of the debts and liabilities. Trying to plan your retirement definitely works because you can see what's going on. And I'd much rather have an awkward conversation with a client outlining that it's better to retire a year later because it does X, Y, Z, than someone phoning saying, I'm short, what can I do? And that's where it doesn't work. So just be careful that you'll have lots of friends and colleagues that have come up with perfect master plans, but it was for their situation. And the chances are your finances, despite earning the same amount, will be very different behind the scenes. Vanessa, I took my pension when I was 55, that then paid into the pension for another year. When can I get this money? Right, okay, so Vanessa, I'm assuming you paid into the 2015 scheme. If so, you can actually take it now. But if you are 56 or thereabouts, and your state retirement age is 67, you're going 11 years early. You're going to lose over a third of that 2015 scheme. So can I access it? The answer is yes, but there's a huge reduction that would apply. So it may well be, depending on how much it is, and if you desperately need it, the longer you leave it, the closer to your state retirement age, the greater the amount of benefits you'll get for it, rather than seeing quite a significant reduction. Okay, yeah, you took both. Oh, crumbs. At 55, the 2015 scheme would have been reduced quite heavily at that point. Marion, I took my 95 scheme, part of pension, 2 years ago when I turned somewhere. I was not given an opportunity to choose where I wanted my pension to be. Okay, yep, it was automatically added to the 95 scheme. I've been told different information about what happens with my 2015 scheme, and that I would still be given an opportunity to review both schemes. That is true. My 2015 statement details does not look accurate. Okay, I checked. Right, okay. Marion, I only needed to read the last sentence. I will pop within the email an email address that says, can I have a manual estimate of benefits? I can't access the statement. And it will show you. They'll email you back showing your pension is now worth X or Y. Jane, oh, crumbs. Right. No, Jane, you're definitely not stuck working until age 70. Except we've got a mortgage, and it depends on your expenditure. So I'm not sure if everyone can see these, but there's been a divorce in the background. There's a mortgage now running until late 60s, early 70s, and am I stuck working until that point? I would hope that depending on your age now, what you'd be able to look at two things. Overpaying of the mortgage if you have spare income, and I appreciate not everyone does. Okay, crumbs, we've got 16 years to get sorted, but overpaying of a mortgage will just mean that two things: the debt reduces and you pay less interest. So it could well be that even a nominal overpayment, £50 or £100 a month now, doesn't sound significant, but it compounds. So it gets better and better. At age 65, you'll be able to draw the 2008 scheme without reduction. And as mentioned to one of the earlier answers earlier on, you'll be able to access a pension and lump sum at that point. So two scenarios. If you take a lump sum, depending on how much the mortgage balance is at that time, you could use some or all of it to clear or reduce the mortgage down. You'd also be in receipt of your 2008 pension. So that gives you, again, two options. If the mortgage is gone, you may not need to work quite as hard or at all. If the mortgage still exists, what you could do is slow down and use the pension, the 2008 scheme pension, to pay some or all of the mortgage payments. So it may be that stuck working till 70, I'd hope not, but it could be that working at the pace you're working at now, maybe not. Reducing the workload the closer you get to 65 and beyond may well be the light on at the end of the tunnel that makes things look slightly more palatable, if that's okay. I hope that's a nice enough answer, that one. I'm very mindful of time. I don't want to. Oh, crumbs. Janine, are we able to contribute more of our pension? You are. As the GP practices, if everyone is within GP practices or the ICB, effectively the partnership or the ICB will pay 14.38% towards your pension. So your pensionable income is expensive for the practice, for the trust, for the employers. If you individually want to pay more in, you can either look at within the NHS additional pension, which effectively buys a block of income. It's in blocks of £250, but from retirement, or in-house additional voluntary contributions, which are effectively investment linked. So they go up and down with the market. I've got nothing that I can give in terms of certainty around what Donald Trump will say today or tomorrow and how the markets will react. But you can certainly pay more in. Additional pension is probably the first port of call that most would go to first. Mel, has that been okay? It does come out before tax, yes. As things stand, Janine, with the budget in 3 weeks that I don't think anyone is prepared for, we have to now say, as things stand, after every answer I give at the moment, dear Rachel is going to do something. We're just not sure what. But we shall find out quite soon, sadly, on that one. Mel, Ben, Craig, anyone? Was that okay? Hopefully took a few questions. That's me, but I'll ping you guys an email.
Absolutely perfect, in my opinion.
Crikey.
Are there any other questions before we call it a day? As I mentioned previously, I will definitely be posting the recording of this video. As I mentioned at the beginning, it's entirely possible that we may need to arrange a follow-up session in the early new year, but for now it will go up just in case anybody else couldn't view any of your colleagues that maybe have been involved in the clinical one as well. So thank you so much. Seeing a lot of thumbs up, but no more questions by the looks of it, which is brilliant. Just to remind you, the feedback form, I'm just about to post it into the chat now. So, Paul, thank you very much. Really appreciate it.
No trouble. I'll pop that email across to you now, Craig. So you've got almost a hit list of things that might be helpful for everyone.
Fantastic.
So they can get on and sort things.
Yeah. And if you've got any slides that you can share, that would be fantastic as well.
Consider it done. Have a good afternoon, all. I'll speak to you soon.
Fantastic. Take care.
Take care. Bye-bye.
Hi, folks. Well, I hope that was informative. As I say, please fill out the feedback form that I've just posted into the chat. I will email everybody probably tomorrow morning with the link to the form as well, just so that you've got it for definite. If you can fill that in, you get your certificate on the back of it, but also more importantly for us, it's the fact that we can get your feedback on this and any suggestions of topics that you'd like to have covered in future events. So from my side, I think that's about everything, unless anybody has any questions. Which I think I've got away with. So that